Okay, so this is an overview of preventing infections in transplant patients. This is a very big topic, obviously, but so what I've done is really just giving you the bird's eye view in a way that hopefully can improve practice, or at least get you interested if you're involved in these sort of patients. And there's references throughout, and there's a lot of resources you can go further in if you want. But in general, the problem really obviously comes in the fact that infections are by far the largest cause of morbidity and mortality in most transplant patients, especially in the first year. After that, it becomes other issues about rejection and things. And of course, you can have rejection early and you can have very early occasionally, but infections really are the number one reason people do badly in transplantation. So it's a really important thing, and people forget that. And it's also very complicated because the way infections present in transplant patients is often very different to how they present in other patients. And so you really do need to know a little bit about it. It's one of the most intense parts of infectious diseases you can find. The first step, and I'm going to give you a nice overview, but the first step is this pre-transplant workup. So this is what you do for potential recipients. It's routinely done in high-income settings. It's done pretty poorly in South Africa, and it's a really crucial part. So what does this comprise of, rather? Even in high-income settings, the pre-transplant workup timing is often not optimal. In one study here, this was done in Italy, the patients awaiting kidney transplant, they did a pre-transplant workup in only about 43% prior to dialysis. And remember, if you're not going to get it right in a kidney transplant, which has usually got the longest lead time before you need a transplant, because you can put people on dialysis for quite a long time. If you're not going to get it right in kidney transplant, you're not going to get it right in anyone. And the workup here took about 8 months, which is astronomical. So we can all do better. What does this comprise of? The first component is to screen for active infections, and I'm going to take you through each one of these. The second component is to screen for latent infections, then to detect the MDR-resistant organisms, and then vaccination. So those are the 4 pillars of a pre-transplant workup. So let's go through them one by one. Screening for active infections is obvious, and it's not usually that tricky. It does help to know a little bit about the organs. So if you're in a setting where they have a lot of transplants, for example, if you're the infectious diseases doctor, or if you're the clinician, you often just deal with the liver team, or just deal with the lung team, or just deal with the heart team if there's enough of you. If there's not enough of you, you'll be dealing with all the teams. But you get a bit of experience in each organ as to what the likely sources of infection are. Some of them can be quite occult. So, for example, if you have a patient waiting for a heart transplant, if they have a ventricular assist device, which really just helps effectively contract fluid in the left ventricle, that often is lined with infectious material. It's basically impossible not to get it infected, at least if you've had it in any length of time. And so, for example, that's a good place to look if you're worried about occult infections. If you have a patient waiting for a lung transplant, depending on what the problem is, but it's often something like cystic fibrosis, there may be aspergillosis, there may be TB, respiratory viruses. So it's helpful to know in each organ where to look. In general, you should, if you find an infection, treat it, at least get it under control, even if you can't eradicate it completely, and only then do the transplants. In other words, if you find something, you delay the transplant. Clearly, this is a case-by-case basis. There are going to be people who you can't wait for. But in general, if you can wait, there's evidence that you get better outcomes if you do wait. That stands to reason, but it's nice to know that there's some evidence behind it too. That's pretty straightforward. What about the latent infections? That's a lot harder. The basics are on this page. Basically, every patient needing to go for a transplant should get what's on this page in South Africa. And you may have a lot more things that you need to be doing as well. But in South Africa, at least that. So there's a lot of viruses stuff to do. HIV stands to reason. CMV and EBV we'll talk about. Lyle's going to talk about CMV, hepatitis B and C. For parasitic infections, toxoplasmosis is the big one. The reason for that is that it's actually a surprisingly common transplant infection if you don't think of it, especially in heart transplants, where you might actually bring from the donor occult toxoplasmosis in via the heart. That's already in the muscle of the heart. And then when you get immunosuppressed, it reactivates and causes a really bad myositis, or myocarditis rather. Screening for strongyloides is also important in South Africa. We do have strongyloides here in South Africa. Not sure how much of it's there. You can screen by the stool, but in fact, immunoglobulins, if they're available as they are in private, are a better way of screening, at least for this. And remember, this is the danger here is post-transplant again, when you're immunosuppressed, especially if you give steroids, which is common in a post-transplant setting, then you get hyperinfection syndrome, where strongyloides goes bananas and really starts causing problems and going into this hyperinfection cycle within you. And so in other words, the point here is it's not like you will necessarily see the eggs or not the eggs, the larvae before your transplant. It might be very occult. You might not know anything about strongyloides, but yet suddenly afterwards, when you give the steroids, it goes crazy. So it's worth screening for before. TB, very complicated, but obviously a huge burden in South Africa, and then syphilis as well. There may be other things to add, and that's part of the pre-transplant workup's job. In other words, part of the job is to go through in minute detail with a patient. What's their life like? What do they do for fun? And what hobbies do they have? What travel do they have? What pets do they have? What do they eat, for example? You need to go into a lot of detail, and based on those things, you might want to add and screen for other things. But as a minimum, what's on this page should be done. CMV is a tricky thing, and Lyle's going to cover that next. So I just want to show you really the one slide on here. Just remember that what's high risk and low risk depends on the type of transplant. In a solid organ transplant, the highest risk is when the donor is CMV positive, and we're talking serology here. So you're doing CMV IgG. The donor is positive, but the recipient's negative. That's highest risk because you're going to get some CMV exposure from the organ. Even if you try and wash it out, there's always a bit of CMV in there. But yet you don't have any immunity to it. You're the recipient being negative, and we're going to immunosuppress you. So you can't generate immunity easily afterwards either. So that's the highest risk. Whereas the opposite applies in blood hematological stem cell transplants, where because you effectively get the recipient gets the donor's immunity, if you think of it that way, via the stem cell transplant. The opposite is the problem. So in other words, if the donor is negative, you know they don't have any immunity. You are positive, so you have CMV in some of your cells, but now you get the stem cell transplant that you become basically, we deprive you of immunity through stem cell transplant, and that's the highest risk because again, you're not going to be able to generate immunity easily in the post-transplant setting given the immunosuppression. The good news is Lyle, the handsome person depicted over there, will tell you next about CMV in a lot more detail. So we're going to come back to that. EBV is important. People always forget why it's important. It's not really that it reactivates. It's not like CMV, which reactivates and causes all sorts of trouble. EBV is not really, doesn't have a post-primary infection syndrome. So if it reactivates the second time, it's not a big problem usually. The issue is its oncogenic potential. Specifically in post-transplant setting, this entity called post-transplant lymphoproliferative disorders, PTLD. That's a spectrum of lymphoproliferative disorders ranging from just sort of asymptomatic replication all the way to florid lymphoma. And you need to know about it because similar to EBV, there's high risk and low risk states. Children suffer more from it, but in adults, if you are high risk, in other words, again, like same, I'm going to go back, same like CMV, if you're getting a solid organ and you are donor positive, or they are donor positive for EBV and you're recipient negative, that's going to put you at higher risk of PTLD. This is a PET scan showing some foci of lymphoproliferation. And if it's there, you can do something about it. So you could tape the immunosuppressives, you could give preemptive treatment with rituximab and things like that. There's a range of options, but you need to know about it. That's why we test for it. Hepatitis B, why do we test for it? Well, in fact, again, it's one of those ones that has a high risk of reactivation. This table shows the risk of reactivation in the lowest risk group of patients, so-called occult hepatitis B patients, where the patient actually is, we're talking about you, the recipient, is surface antigen negative, but you've had old evidence of hepatitis B as evidenced by the positive core antibodies. That you still have a very high risk of reactivation if you're on something like rituximab. But even if you just get steroids or some of these other systemic chemotherapy agents, you're going to have a high enough risk that you need to do something about it. What to do about it is a whole talk in itself. It depends on whether you're getting an organ from, if that organ is a liver or whatever. So the answer, what to do about it, is very complicated, and I'm not going to go through it. But it's really, you just need to know about it. At least you know the possibility. That's why we do hepatitis B screening. And then toxo, I mentioned this already. The problem in solid organ transplantation is mostly transmission via the graft. In other words, it's not really reactivation in you, like many other infections are post-transplant. It's really the other thing. It's whether you're actually getting this toxoplasmosis from the graft. So from the heart that you get transplanted in you has the toxoplasmosis. And then it can reactivate and cause a huge amount of problem. And again, it's not to say that the donor knows that. The donor the deceased donor who's provided the heart, for example, may not have had any clinical problem whatsoever. There's no reason to suspect that toxoplasmosis in their heart. So you have to do the serology in the patient and in the donor, in the recipient and the donor. to check. Obviously, the biggest risk is heart because that's muscle. That's where toxoplasmosis likes hiding. Liver has got a non-trivial risk too, whereas something like a kidney transplants, basically none of them get this. So it does vary quite a lot by organ transplant. It's an important thing to consider, and if people don't consider it, they might. You might think, for example, a new heart transplant is getting rejection, but it's not rejection. It's actually just toxoplasmosis. TB is an enormously complicated issue, and in the FITSA conference, we had an entire talk on this from Ribka Bahani. It was a really excellent talk. I can't do justice other than to say, with her permission, I've just taken this one graphic from her slide to show how much the risk of TB is increased post-transplant. So lung is an enormously high risk. And the thing about solid organs, by the way, is that that organ is always behaves like it's immunocompromised the rest of its life. What I mean by that is, for example, if I get a lung transplant, even when I taper off most immunosuppression and I'm really not that immunocompromised systemically, the lung behaves like it's the dumb stepchild of some awful family. The lung is then the most likely to get infected. And similarly, if you had a kidney, the kidney gets infected way more than you'd think from the level of immunosuppression. So the transplanted organ is always the worst affected in terms of immunosuppression. And for example, if you look at lung 15 times higher, that's higher than HIV positive to negative, for example. We always know how much HIV is a risk factor for TB. Well, lung transplantation is even higher, for example, at least when you count HIV as a whole, given all the CD4 ranges. So it's really, really important. And stem cell transplant almost as high too. What to do about that's actually not clear, because the guidance is often written from a high income setting where it's just about screening for latent TB before you get the transplant and then doing something about the latent TB, because you're not going to get reinfected in, say, America. You're really talking about the people who are often immigrants from high burden countries may have latent TB. If you treat the latent TB, that's as good as you need to do. In South Africa, though, where it's a high burden setting, you have the dual problem of not just the latent TB, but also being exposed to TB just through your average life for the year or two after transplant when your immunosuppression is highest. So what to do is not clear. Some guidance suggests really just watch very closely for active TB. My gut feel here is it's probably not enough. So I think you should either screen for latent TB and treat it like you would in a high-income setting. My preferred option, but there is controversy over this, and no one is entirely sure which way it should be. We don't have enough evidence in these high TB burden settings. My personal preference would be to say, don't even bother screening for latent TB. Just give them, like we do with our HIV positive people, isoniazid, say, or some form of TB preventative therapy for about a year after the transplantation. That's the highest risk immunological period. You're going to treat the latent TB. You're also going to provide something in that first year when they're profoundly immunocompromised. I don't have the greatest evidence for this, so I admit, and there's other approaches that people have tried. That would be my one pager on it, but there's a lot more that needs to be said about this in a high income setting. All right, so that's all the latent infections. Remember, I said there's the four components. We've looked for active infections. We've looked for latent infections. Now I just want to know about multi-drug resistant organism colonization. Why is this important? Is because I'm going to give some transplant antibiotics around the time of surgery and in the immediate few days afterwards. And I don't want to just standardize that if I already know the patient's got these multi-drug resistant pathogens. A classic example of that is a lung transplant, where if, say, in a cystic fibrosis patient, the sinuses are as badly affected as the lungs. Obviously, it's the same pathology. If I'm going to give a lung transplant, I'm going to take out the lung, put a new lung in, or double lung transplant. But the problem is I still have the same infections in the sinuses, which just go straight back down and infect the lungs with the same bugs. So if I know there's an organism in the sinuses, for example, in this example, which is multi-drug resistant, clearly I want to give the antibiotics that target that in the immediate post-transplant period. So really in the pre-transplant assessment, this means you're going to go back for about a year or more and find all those positive cultures and see if there's anything you want to change about the antibiotic regimen you're going to do. This sounds obvious, but it can be very tricky, obviously. But you should at least look and check what regimens the patient's on. You don't want them failing from a resistant infection, which you could have treated. And then the fourth component of this pre-transplant assessment is the vaccination. We need to be doing this before transplantation wherever possible. It's better than after transplantation. It makes sense. You get a better immune response before transplant to your vaccine, and you carry that with you post-transplant to some degree. So ideally, if you have time, we want to give the vaccines 2 or more weeks before you get transplanted. You get better immunity, and it actually shows a hard endpoint of reduced morbidity in at least 2 or 3 randomized trials. If you can't, well, then you have to give it after transplant. The problem is you can't give live vaccines post-transplantation. So you really have to administer them. If you're going to give any vaccines that are live, we recommend them at least 4 weeks, not 2 weeks, but 4 weeks prior to transplant. And then you cannot give them post-transplant because it's too unsafe. So really, that's another reason to be good about this and make sure you time them correctly. Get someone who knows what they're talking about with vaccines and does this frequently so that you can get as many vaccines as possible in a shorter period of time, because you often don't have a lot of time. Which vaccine should you give? Well, flu vaccine. I'm just going to whiz through this really, just to show you that these are the sort of typical vaccines. There may be other vaccines, by the way, not on this table, that individuals may need, but in general, flu vaccine should be given to all of these transplant patients where possible. Pneumococcal vaccine, and again, the same order as we have pneumococcal vaccination in other people who need both conjugate and the polysaccharide vaccines. Namely, the conjugate comes first, and then the polysaccharide about 8 weeks or more later. That's the best way immunologically to get it right. Hepatitis A is important to do. You can check if the patient's immune to it via IgG, but if they're not, they need the vaccine. Especially important, clearly, in liver and kidney disease. Hepatitis B, similarly, also very important in liver disease, but in general, you'd give it to everyone, every transplant patient. You don't want bad hepatitis B or A because you have poor immunity if you can avoid it. And again, for hepatitis B, if you're not sure, you can screen them with antibodies. And again, if they're negative, then you need a vaccine series. Varicella or zoster vaccines, obviously they're different. You can varicella zoster, varicella vaccines are different to the zoster vaccines, but you need one of them at least. And again, the outcomes are much worse in transplant patients with them. And the problem here is that they're live vaccines. There is a non-live vaccine which is around in the US, which will hopefully come around soon in South Africa. But until that point, we really only have the live vaccines. And so you really have to get them in before transplantation. COVID vaccine, obviously, as well. MMR vaccine is important, particularly for rubella, because, again, you don't want women of childbearing age getting pregnant post-transplant and getting really bad congenital rubella because they didn't have enough immunity because they were immunocompromised when you could have given a vaccine. Again, the MMR vaccine is live. You have to give it before. HPV makes a lot of sense as well. We know that T-cell immunity is important for HPV control. If you can give it, again, assuming they meet age criteria, you should give it. And then the Tdap one, so tetanus, diphtheria, and acellular pertussis. Again, you can get tetanus post-surgery, especially the lung transplants, which have these awful kind of scars on the chest. And then pertussis is also worse in transplant patients. All right. So that's a kind of overview. These are mostly straightforward, but remember that where people forget is they forget about vaccinating the other household members. It's clearly important to vaccinate as many people around these patients as possible. Post-transplant, their biggest risk is not the community as a whole, but their immediate household contacts, because that's who they are around the most. So you need to be vaccinating the other people they stay with, their wives, their children, for example, if they're in the same household. Flu vaccine, pneumococcal vaccine, MMR, rotavirus vaccine, varicella zoster vaccine, etc. You need all of those vaccines and as many as possible that might impact on the transplant recipient. Don't forget about that. People do forget about that, and they just vaccinate the transplant recipient rather than everyone else. There are a few nuances to this. There's a whole paper on this, which is fascinating to read, and there's guidelines on this, but I just picked out a few of the more interesting ones. If you are the recipient of a transplant, in other words, you're already immunocompromised, or you're immunocompromised before your transplant, you shouldn't probably avoid handling diapers of infants who've been vaccinated with the rotavirus vaccine in the 4 weeks before. So you can palm this off on your partner and tell them you have a medical reason not to change the diaper, which will be delightful. Otherwise, you should avoid contact with people who get a skin rash after the varicella or the zoster vaccines. That's not common, but occasionally people do, and there is a small amount of virus in those skin rashes because it's a live virus, remember, and that can be a problem for immunocompromised people. And then there's one vaccine which you actually should not give to household contacts, which is obvious when you think about it, and that's the oral polio vaccine. So that's one vaccine which you just should not give to household contacts if you have a transplant patient who's profoundly immunocompromised in the same household. All right, happy with that. That's the pre-transplant workup. The second big way you can reduce infections is donor-derived infections, which I'm going to be super quick about because it's a huge topic in itself, but there's a lot of really interesting things. I'm just going to find 1 or 2 points about this to you. This was donor-derived potential transmissions that were reported to the network in America over a period. And you can see if you just concentrate on the bottom there were nearly 2,000 reports involving nearly 5,500 recipients, because obviously one donor can go to multiple recipients depending on the scenario. And then they proved transmission. This network, by the way, is designed to overcall it. So in other words, you're actually obligated by law to report possible issues. And then only in minority of cases was there actually provable transmission, but still about 16%. And then the deaths were about 15% of the transmission. So it's actually quite, if you do get a donor-derived infection, it's quite lethal. I mean, you think about it, it's 15% is way higher than most infections if you're in hospital. What were these infections? That's the list. I just put it up there for your interest. The virus is always the ones people worry about, and you can see what the range was there. This is actually in order. So adenovirus was the most common, then Hep B, Hep C, hepatitis E virus, HHV-H. Some of them were HIV, can you imagine? Herpes simplex, flu, things like that. West Nile virus is a lethal one, but obviously quite a small chance. The bacteria are mostly the standard ones, but look, also the equivalent of tick bite fever for the Americans, Rocky Mountain spotted fever, nocardia, interesting, listeria, fungi, Aspergillus candida, coccidioidomycosis, so in our case would be histoplasmosis, cryptococcus. Can you imagine giving someone cryptococcus post-transplant? TB has been shown to be transmissible, same as MAC. And things like that. The parasites, look at the Balamuthia, the free-living amoebae, trypanosomiasis, Naegleria, schistosomiasis, all hectic infections. And you can imagine how difficult that can be to find post-transplant. The general principles of this is that you should have a system where you're systematically reporting these issues. For example, if the donor's culture after transplant turns positive and it's now grown something, you should report that as a matter of obligation. It shouldn't be an ad hoc method like we do in South Africa most of the way. In the US, it's actually legally mandated to report any issue like that, even if you don't know that it's caused an infection, even if it could have caused an infection, you have to report it. In other countries like Europe and Australia, they have dedicated reporting platforms such as Eurotransplant in Australia, but it's voluntary, it's not legally mandated. In South Africa, it's mostly just ad hoc. What do you do about reducing the risk of this? Well, you should stratify the donor. And why is that important? So for example, if this donor is an IV drug user, then you know already they're going to be at higher risk of transmitting hepatitis B, hepatitis C, and HIV, for example, which means there's something you do more in the recipient, even if obviously you're testing the person for that, but they might be in the window period. So in the recipient's case, the donor's case, or maybe it was just too soon and you had to do the transplant before you even got those results back. But if you still risk stratify, there's things you can do in the recipient, and you can be more good about following them up, for example, and I'll show you an example of that next. You should also do a good assessment of the donor and the donor organs. Why did the person die is a really important question to always ask, and that should be obvious to the transplant recipient team. So, for example, in Donald Gordon, if you're getting a liver from someone, that team should know absolutely clearly why the recipient died. And if there's any outstanding blood results that needs to be followed up. And you need to be routinely screening the donor for any infections. This is an example of some of the management principles. What if the donor comes back with a bacteremia? And that may be, like I said, after you've transplanted the patient. You transplant the patient, then tomorrow the donor's blood culture turns positive for Staph aureus. What do? So if you happen to know already before transplant, you should ideally give them 24, 48 hours at least and check that they have a clinical response before harvesting the organ at all. And that can be true of a deceased donor as well. Remember, you can give them antibiotics for 24 hours, potentially, depending on how stable they are. If you can't, well, then it's tough luck. But either way, you're going to treat the recipient for at least 7 days. Also look for the metastatic complications of that infection. What about a donor with a multi-drug resistant organism? The advice there is to talk to the transplant team just to check you can treat it. There are some, for example, in cystic fibrosis, there are some pathogens which are regarded as contraindications to transplantation because you can't completely rid the organ of it. And if you give it to a new donor, they're just going to get that infection, which is functionally untreatable. What about bacterial meningitis or even Naegleria fowleri, which is that free-living amoebae? There's actually good evidence you can transplant them, but they still suggest you should try and treat the donor for 24, 48 hours and then transplant them and treat the recipient as well. Why? You think, well, why if a meningitis, what does it matter if I'm going to give a liver? The answer is that many times people with meningitis actually have systemic infection. So they have, say, strep pneumo meningitis, but they've also got strep pneumo in the blood, strep pneumo in the lungs or something like that. So that's why they're advised to give the antibiotics anyway. The big worry, the thing that sends nightmares up any transplant doctor's spine and into their brain is encephalitis that's unknown encephalitis. In other words, encephalitis without a proven cause. In general, you don't transplant those patients because it's usually something horrible and viral, or it's at least a high percentage of chances, or not even viral, but something awful to treat that doesn't get better when you transplant them. That's, for example, how you get post-transplant rabies, post-transplant West Nile, all of these things. There are always exceptions. I'm not saying every case, but in general, the encephalitis is something to avoid. And then the recipients of organs from high-risk donors, this is where I said we give the example. So what if it's an IV drug user who had an overdose? Well, the organs are often in good shape, but you know that the recipient is at higher risk of HIV, hepatitis B, and hepatitis C. So even if their donor tests negative, and by the way, they don't have to test negative always. Hepatitis C, for example, is an interesting one where it's so curable. With consent, you could transplant those organs and just treat the recipient. But either way, in general, you're going to be doing PCR testing at, say, about a month afterwards, even if the donor tested negative. And with the recipient with hepatitis B, they recommend testing again at about a year because it's got a longer window period and it may not be positive about a month. All right. And then when to suspect them? Well, early transplant infections, because remember, in the early phase, you don't often get weird opportunistic infections. If you do, it's often a post-transplant. It's a donor-derived infection. Anything that's a bit weird in clinical course, so you'd expect this is a bit odd, the patient's not settling fever-wise, or they have odd signs and symptoms. And then any sort of encephalitis, which, like I said, is the worry. Any post-transplant encephalitis, you really do worry about any donor-derived infections. What do we do about this? Well, in one graphic at the bottom, the principles are to report and communicate. In other words, make sure you're reporting this to everyone who needs to, communicate to the team. Retain the specimens. Remember, run down to the micro lab and make sure they don't throw away the blood samples from the donor or the recipient, or any CSF samples or anything like that, because you're now going to need to test them for a range of other things. And then do whatever tests, and this is really need an infectious diseases doctor at this point to know which sort of tests to test for and how to manage them. Third component, we talked about pre-transplant assessment, we've talked about donor-derived infections. The third component is this post-transplant prophylaxis, which is a nightmare in itself, and I'm just going to show you an example of this. What do you do about this? This is about giving antibiotics and antifungal agents and antiviral agents sometimes, and it depends what that regimen is going to depend on, the solid organ versus stem cell transplant. Within the organs, it's going to depend on which organ it is. It's going to depend on the immunosuppressive regimens. It's going to depend on whether you have evidences of rejection or not. So there's no one-size-fits-all regimen. I'm going to give you one example of what the team that I worked with in the US did. But the key thing really is to know about the timing of infections with this. This is a sort of table that you get to spit out pretty easily if you do transplant infectious disease for any length of time. The principles here is really the timing. So in the first month, if you get an infection, it's usually nosocomial infection or post-surgical, I mean a surgical complication like a bile duct injury or something causing an infection, or that donor-derived infection, like I said. You don't get the big opportunistic infections outside the donor-derived ones in the first month because you just haven't been immunocompromised for long enough. Where you get the opportunistic infections and the reactivation of latent infections is usually a little bit later. It's in the sort of 1 to 6 month period, roughly. And there you're going to get the listerias, nocardias, all these weird viruses, TB, etc. Whereas after that, in about 6 months post, usually by then the immunosuppression is tailed down unless you've had a lot of rejection episodes. And so you're now returning to something a bit more normal, like community-acquired infections. But if you end up with rejection or if you're on high dose immunosuppressives, you still then can move back to that point, the 1 to 6 months where you get all these weird opportunistic infections. These are the sort of troublesome bugs to care about. There's 4 viruses, 4 fungi, 1 protozoan, and bacteria in general in the neutropenic patients, especially the enteric ones. There are clearly more than this, but these are the big ones to think about. What are you going to do routinely about prophylaxing? You might do nothing, but you have to at least consider each of these bugs to decide if you're going to do anything about them in a post-transplant setting. It's not the only ones that can cause infection, but these are the ones to think about in terms of prophylaxis. This is one example from the lung transplant team. They individualized their peri-transplant regimen based on the patient's cultures. For CMV, if they were high risk, they gave ganciclovir until they could, and when they could swallow valganciclovir, and they gave it for 12 months because, as Lyle will show, lung is quite a high-risk organism for CMV. EBV, they just monitored the PCRs if you were high risk. PJP, they gave Bactrim, and in the case of a lung, it's going to be lifelong because that lung, like I said, never really gets totally immunocompetent because it's a transplanted organ. And so 1 single strength tablet daily for the rest of their lives to prevent PJP. And then in the immediate post-transplant period, they also prophylaxed against aspergillus and fungi, other fungi, with voriconazole and inhaled amphotericin B, actually. until the voriconazole was therapeutic, and after that, voriconazole alone for 3 months. I don't mean to give this as the model answer or anything. This is one approach. People have different approaches. And then there was a totally different approach if they had rejection, where they had to go back and add a few other things. I'm going to skip past this. I'm showing it for illustration, not to really get any sort of memorization going. And then what about stem cell transplants? Here, it's a bit different. Again, I'm going to show you one example. People do different things. Don't panic if your team does different. I'm just going to show you an example and walk you through this. Here, for the neutropenic patients, you really do need to prophylax against bacteria. There's good evidence for cotrimoxazole and levofloxacin. You're going to give cotrimoxazole, it's actually less side effects, for example. The problem is, of course, it suppresses bone marrow, and in a stem cell transplant, you can't have that. So they would stop the cotrimoxazole about 2 days before the implantation, and then they would switch to levofloxacin actually until engraftment occurred and the cells had recovered. And then by then you could stop it. If you did need to continue for whatever reason, you could switch back to cotrimoxazole at that point. The viruses, if you were IgG positive, you get acyclovir. If you were VZV IgG positive, you get acyclovir for up to a year. And then for fungi, for really to prevent Candida, you would start from the day of the stem cell transplant all the way through to day 75. Whereas PJP, you're only going to start, because remember how you're going to prevent PJP? Well, that's the Bactrim, and we're only going to start around the time of engraftment, not in the early stem cell transplant, where it could affect the bone marrow's ability to proliferate. Okay, I show you this as an example. This is clearly a key part. What you really need is every organ to have its own protocols, every sort of scenario to have its own protocols. If you look, for example, if I looked at the lung transplant guideline from the University of North Carolina, it was a 25-page booklet of SOPs in terms of preventing infections. It's clearly very detailed, and it's really important that each transplant team develops their own process according to the best evidence of the time. And then the very final part is about these strategies for safe living following transplantation. So this is the part that the patients hate, but this is actually done mostly in the pre-transplant assessment, actually. But it's really, I've put it last because it only applies really from transplant onwards mostly. You've sat with the patient and you've worked through their life. Where do they live? Where do they travel? What house? What amenities do they have? How pets and animal exposures do they have? What are their hobbies? What do they do? Gardening, etc. You know as much as you can about their life as possible. And then what you need to be doing is tailoring an individual kind of guide to how to prevent infections around them. So you should try and prevent infections transmitted by contact, prevent infections of respiratory nature, provide them advice about food and water safety, animal contact and pet safety, safer sex practices, and travel safety. And obviously, this is an enormous big guide. I'm going to show you just a few examples. For example, you would say to the patient, please, post-transplant, avoid close contact with people with respiratory illness. So in other words, if someone's coming around and they've got a cold, tell them no. It may give a cold pre-transplant. Post-transplant, it may give you a life-threatening infection. Tell them to stay away. Avoid crowded areas, for example, like shopping centers, especially during the period of enhanced immunosuppression. Clearly, you can't tell someone to avoid crowded areas for the rest of their life. They need to go shopping. But in the immediate post-trans, when the immunosuppression is high, that's really a bad idea. If you're going to catch flu and things like that, you're going to catch it at these crowded areas. It's important. Avoid drinking unpasteurized milk, for example. Avoid eating raw and undercooked seafood because you can get Vibrio infections, particularly when you're immunocompromised. Undercooked meat, bacterial contaminations, toxoplasmosis, tapeworms, etc. I put a sad face there because it really does suck the marrow out of life a little bit, telling the patients this. So it's really important to not overshoot and just give them 1,000 things, but really to work with them, individualize it based on their life choices and what they want to do, and try and find the high impact things that you can tell them, at least for a time limited period, to avoid, to try and maximize this. Robin Avery is the first author on this paper. That's a kind of classic paper for, and she's been doing this for years. She's from Harvard. She's been sucking the marrow out of life, enjoyment for decades about safe living following organ transplantation. But there's papers you can go to get the sort of full list of this. But like I said, don't overshoot. You need to find something that the patient will adhere to. And that's it. So I'm going to stop there. Really, what I want to summarize again is the spectrum of preventing infections in transplant patients. Do the pre-transplant workup. If you don't, you should try if you're in a center that does it. And really need an infectious diseases doctor to help you out here. And they screen for active infections, screen for latent infections, detect the drug-resistant organisms, and have a vaccination plan. Look about the donor-derived infections, mitigate the risk wherever possible, such as give 24 hours, 48 hours of antibiotics before transplanting if they have a bacteremia, etc. Suspect them, test them, and treat them. Post-transplant prophylaxis is organ-specific and patient-specific, and I've given you 2 examples, but clearly you're going to need individualized advice for that. And then lastly, safe living strategies, which is these aspects over here, which is covered usually in the pre-transplant assessment with the patient, but really applies post-transplant. If you do this, you can reduce substantially the amount of infections people get, and it's really rewarding, and the outcomes improve. We have evidence of this. The morbidity and mortality even improves post-transplant with a good infectious diseases input. Infectious diseases are absolutely essential for transplant patients and needs to be part of any transplant team that takes itself seriously. So thank you very much. I'm going to pause there, and I'm going to stop there, in fact. And what I'm going to do, just in the interest of time, I'm going to just hand over to Lyle to do this next. But what I'll do is I'll have a look in the chat once I've put the CPD link up, and I'll answer any questions you have in the chat at that point. So thanks very much, and over to you, Lyle.
Thanks for such an awesome overview, Jeremy. Let me just show that. Great. So I'm going to focus on one of these infections. I'm focusing on CMV. And I'll just go through a little bit of background, talk about two major components of managing CMV. One is preventing it, and then also treating CMV disease in transplant patients. So go through a little bit of virology, look at a few CMV definitions, look at what makes the transplant recipient special, then look at the ways to prevent CMV disease, mainly via two kind of approaches, although some units do use a kind of hybrid approach, and then look at how do we treat CMV disease if we're not successful at preventing it. So in terms of background, CMV is one of the most significant pathogens after transplant in both solid organ and hematopoietic stem cell transplant. It is a herpes virus amongst the other herpes viruses that are pretty well known to you all, and it gets its name from the enlargement of infected cells. So cyto meaning cell, mega meaning large. So if you've seen any histology slides, you'll see that it causes enlargement of cells, so cytomegalovirus. It replicates only in human cells and actually much more slowly than other herpes viruses, so for example, HSV or varicella zoster. It's spread through bodily fluids, so saliva, breast milk, blood, obviously, sexual contact as well. Most infections, if you're immune competent, are asymptomatic, although if you can have a mononucleosis-like illness, and that can present with fever, lymphadenopathy, and even a hepatitis. But if you're immune compromised, it can cause quite significant disease. So if we know the CMV pneumonitis, or if you in HIV positive patients with advanced immune suppression, CMV retinitis, but it can really affect almost any organ. After initial infection, it establishes latency in cells of your immune system, so including monocytes, macrophages, and CD34 positive cells. And that can be the source for reactivation at a later stage. So generally, in any population, as people age, seropositivity increases. Also, in areas with poorer socioeconomic status, people living close together, spread of CMV occurs more, and so serological status is increased. So if we look at the African region, generally about 90% of patients or people would be CMV seropositive. So they have been exposed to CMV and will have a positive CMV IgG. And if we look at South Africa, our rates are pretty much in there between 80 and 90%. So that means that if you are a transplant recipient, or if you're looking at potential donors, that the majority of them will be CMV seropositive. So CMV infection is the presence of CMV replication in tissue, blood, or other bodily fluids. So that is replication regardless of symptoms. And then you can basically divide up CMV infection into CMV disease. So that's CMV infection with clinical signs and symptoms, and that can be end organ disease, as I mentioned, things like CMV pneumonitis, colitis, retinitis, or the CMV syndrome, where there's no specific organ disease, but there's the syndrome, which has got certain criteria, which include things like fever, leukopenia, atypical lymphocytes, etc. And then obviously you can have asymptomatic CMV infection where you've got a positive, say, viral load, but without any symptoms of disease. So what makes a transplant recipient special? Well, obviously when you have a patient who has been transplanted, the level of immune suppression is really a balance between the risk of opportunistic infection and the risk of organ rejection. And so this is a balance that's very difficult to maintain and to achieve for anyone who's looking after a patient who's been transplanted. Just as an indication, so if you reduce the level of immune suppression, you may reduce the risk of opportunistic infection, but then you increase the risk of organ rejection. And likewise, if you increase the level of immune suppression, so you decrease your risk of organ rejection, but you do then increase your risk of opportunistic infection. So this balance is quite difficult to maintain. What kind of problems does CMV cause for the transplant recipient? Well, you get the direct effects, and so those are the effects that I spoke about now. So the direct effects in terms of CMV organ disease and CMV syndrome, but also the indirect effects. So these are effects that do not occur directly due to the virus and the viral kind of cytopathic effect, but do occur due to the immunological effects of the virus. And this can include an increased rate of acute and chronic rejection, as well as increased cardiovascular disease, increased rate of other opportunistic infections and malignancies, and also metabolic consequences such as onset of diabetes, or more associated with patients who have transplant patients with CMV. What are the risk factors for CMV disease? So there are some that are kind of classic risk factors. So this would be regardless of the type of organ transplant, but a donor and recipient CMV serological mismatch, and I'll look at describe a bit more detail how this applies itself. The use of T-cell depleting induction in early post-transplant as part of the transplant procedure. The net state of immune suppression. So how immune suppressed is the patient generally? Obviously, as age increases, risk of CMV disease increases, as well as when there are other comorbidities as well. And then the type of transplant plays a significant role. So if we look at hematopoietic cell transplant, if it's an autologous transplant, risk, this is for patients who, these rates are for people who do not receive any prophylaxis. This is what would happen if someone was transplanted and then not either monitored or received prophylaxis. So autologous, about 5% of patients would develop CMV disease, but allogeneic, obviously because higher levels of immune suppression are required, about 30%. Whereas if we look at solid organ transplant, like Jeremy suggested, lung is most probably the highest risk for CMV disease, or obviously heart, lung, pancreas transplants particularly, so pancreas on their own or with a renal transplant, and then other solid organs like liver, heart, and kidney rates up to about 30%. This is obviously in the absence of using anything to prevent infection. So the risk factors for serological mismatch. So this is a mismatch between the donor and the recipient for CMV specifically. So for solid organ transplant, the people at highest risk is when the recipient is serologically negative for CMV and the donor is positive. And you can imagine why. So you're transplanting an organ that may contain some of these cells that include latent CMV and into a patient who's now immune suppressed and has never seen CMV before, as indicated by a negative CMV IgG. An intermediate risk would be any recipient that is CMV IgG positive, with the donor either being negative or the donor being positive, and where the recipient is positive and the donor is positive, that risk is a little higher than where the donor was negative. And then low risk if both recipient and donor are CMV negative. For hematopoietic cell transplant, the highest risk is different. So if the recipient is CMV IgG positive and is then given a donor, a stem cell transplant from a donor that is negative, you're basically transplanting in CMV terms, a naive immune system to someone who has got CMV living latently in some cells. And so obviously that risk is high. and then lower risks for if obviously the donor and the recipient are both serologically negative. It doesn't mean you can't get CMV, because obviously you can get primary CMV from another source. So generally, there are two major methods or approaches to preventing CMV, and it's not always true, that statement, because sometimes some centers use a hybrid approach where they'll use either a combination of preemptive therapy or combination of antiviral prophylaxis and then preemptive therapy. But generally, the one approach is using prophylaxis. And this is usually the method of choice for solid organ transplants, although I'll show you a bit more. It is changing a little bit for certain transplants. So where the donor is CMV positive or the recipient is CMV positive, then transplant recipient will receive prophylaxis regardless. And this prophylaxis is normally valganciclovir, and the duration is normally defined. So for, say, lung transplantation, because it's a higher risk, for about 12 months, but for other transplants, between 3 and 6 months. So this is generally given regardless, and in these cases, unless there's clinical evidence of CMV disease, it would then be unnecessary to monitor, say, a CMV viral load. The benefit is it does prevent opportunistic infection, because drugs like valganciclovir are relatively broad and cover some other herpes viruses, and it is associated with reduced graft loss and mortality. But as I said, there are some exceptions. So this method of using universal prophylaxis has been favored by some centers, or at least the preemptive therapy has been favored by some centers over prophylaxis, and based on this initial study, which showed that at least in liver transplants, where patients were randomized to either receive prophylaxis or to get preemptive therapy, and I'll go through what preemptive therapy is in a bit, those with preemptive therapy had a 10% lower rate of CMV disease, and also in terms of costs, it saved them about $9,000 per patient, obviously because these patients were not receiving a prophylaxis for that whole period. Acyclovir and valacyclovir can also be used for prophylaxis, and Jeremy did show there in patients that are considered low risk for CMV disease. This study from 2015 looked at valganciclovir versus valacyclovir, showed that at least in terms of preventing CMV disease, it was non-inferior, but you do have to use quite high doses. And in this study, at least, acute rejection was a bit higher in the valacyclovir group. So it is an option. Particularly, this was renal transplant, but you have to choose your patients quite carefully. So preemptive therapy is basically watching a patient, so doing surveillance for CMV by doing, say, a CMV viral load with a predefined threshold for initiation of CMV treatment. So monitoring them weekly, and then for normally a certain period of time, say about 3 months before you would stop, although that period is variable. And then if the viral load blips up to a certain period with a predefined threshold, say 1,000, I mean, there are different protocols will use different thresholds, you then start CMV treatment. You treat then, and thereafter you stop and continue with surveillance. So what this allows is that CMV viremia can occur, and in many cases will occur, but it occurs in a controlled manner, in a way that then stimulates the immune system to produce anti-CMV immune responses. So it almost simulates an immunization, and it is the method that is preferred in stem cell transplants, mainly because there's a lot of evidence for it in this population, but it avoids having to use valganciclovir in patients that already have a lot of myelosuppression. So if we look at a summary of prophylaxis versus preemptive therapy, prophylaxis is generally more commonly used in solid organ transplants where there's a large evidence base for it. The advantage is it does prevent both the direct and the indirect effects, because you're not getting any viremia. And it means that there's a reduced need for CMV viral load monitoring. But a disadvantage is that as soon as you stop therapy, there's a risk of post-prophylaxis disease. There's obviously a high cost associated with the drugs, and obviously the adverse effects associated with drugs, predominantly cytopenias. And you are going to use these antivirals in a lot more patients than actually may need it, because you're obviously prophylaxing patients, and only a portion of them would actually develop CMV disease. Preemptive therapy is, as I said, more commonly used in stem cell transplant. It prevents you don't get the kind of delayed onset or post-prophylaxis disease. You get less cytopenias. It may be more cost effective because you're not giving all patients treatment for the whole period of observation. And it does allow with acceleration of immune reconstitution and immunity to CMV. But logistically, it can be quite difficult, and really depends on your patient and your ability to monitor patients carefully, as well as whether your patient can come and do viral, say CMV viral loads frequently. And it doesn't prevent the indirect effects, because you are allowing intermittently allowing some viremia. Also, these thresholds, I mentioned 1,000, or there's 5. I mean, there are different criteria, and there's different centers will do something different, but these thresholds are not very well defined, as well as the kind of frequency of testing. And some patients may develop CMV quite quickly in between monitoring, although generally it doesn't happen. Generally, if a patient is monitored relatively frequently, you generally have time to jump in and intervene. So a new drug for prophylaxis is letermovir, which is available in South Africa, launched in September last year. It's a novel terminase complex inhibitor, and its advantage is it's licensed for use particularly in CMV, a recipient positive hematopoietic stem cell transplant, because it has no hematological toxicity, which is obviously one of the major issues with using valganciclovir. But again, just like valganciclovir, it doesn't reduce the risk of post-prophylaxis disease. It is also, patients may develop resistance earlier than using valganciclovir, and it's also very expensive. So at the moment, it costs about 100,000 Rand a month, about 3,400 Rand per tablet, which is obviously a huge amount. So the first major study published in the NEJM compared letermovir versus placebo for patients with hematopoietic stem cell transplant. So it was in this case basically letermovir for prophylaxis versus a preemptive therapy approach, which would usually be used in stem cell transplant patients, and showed that the rate of CMV disease was obviously much lower, but also even compared to placebo, the rates of myelotoxic and nephrotoxic events were similar. So that's really where its benefit is in terms of its lack of myelosuppression. So it has also been used more recently, not only in stem cell transplant patients, but also in solid organ transplants. In a study, it was used against valganciclovir and head-to-head for prophylaxis and renal transplant, and showed that it was non-inferior in terms of preventing disease, but also had a far reduced rates of leukopenia. So there are other newer approaches for prophylaxis. One would be the use of monitoring of CMV-specific immunity. So this may be, this particular study used a CMV-specific ELISpot test, which after prophylaxis was stopped, they then immunity immediately afterwards, and then 1, 2, 3, and 6 months afterwards. And they were able to see that those patients that had either a weak or an absent immune response developed CMV disease much quicker. So this is a test in development, and may help important.
Okay, we seem to have lost Lyle. Let's give him a second to see if we can rejoin. Oh, there he's rejoined. Perfect.
You hear me still?
Yeah, we lost you for a bit, but you're back now.
Okay. I think it's my unstable bits internet.
This was the right slide. You can go ahead from
Yeah,
here.
okay, cool. Yeah, so basically, and then vaccines for CMV are there's been mixed results. It's not a lot of good evidence at all, but a lot of work being done in this field. So it would possibly play a role in vaccinating people who are, say, CMV negative prior to transplant. Some vaccines have also been employed post-transplant. Okay, then treatment of CMV disease. So generally, our treatment of choice would be ganciclovir and valganciclovir. Ganciclovir would use the dose of 5 milligrams per kilogram every 12 hours, and valganciclovir the dose 900 milligrams BD. But this is obviously just based on renal function. Foscarnet and cidofovir are considered second-line agents. There are options, but have terrible side effects. So the question often is, when would you use valganciclovir or ganciclovir? And I think generally the question should really be, when should you use ganciclovir? What particular situation should you use ganciclovir in? Because most of the cases, valganciclovir would be perfectly adequate. So generally where there's poor oral absorption, and also when there's severe disease, and you may want to treat quickly and intensively initially, and then thereafter you may consider stepping down to valganciclovir. How long to treat for? Well, you'd want to treat until there's resolution of clinical symptoms. If you do have a positive viral load that you're measuring, that is where that viral load has been suppressed. If it's a highly sensitive assay, one suppressed level may be okay according to guidelines. At 2 consecutive if it's not a highly sensitive assay, and also for generally at least 2 weeks. How do you monitor? Well, because of its valganciclovir and ganciclovir's myelosuppressive effects, you'd obviously want to check a FBC and differential, as well as check a creatinine at least weekly. If patients are at particular risk, you may want to do it more frequently, and then dose adjust your drug based on the findings. So resistant or refractory CMV disease, you may think that someone has probable refractory CMV infection if there's persistent virus after at least 2 weeks of adequate antiviral therapy. The actual definition would be a CMV viremia. If it's for refractory CMV infection, it would be a CMV viremia that increases by a log in blood or serum after 2 weeks of appropriate therapy. And then drug resistance, which may be a cause of this, really can only be detected by detecting the actual mutations in the particular genes associated with antiviral drug resistance. So there are a bunch of different genes involved: UL97, UL54, and UL27 most frequently involved. But who are the patients that are at risk of resistant or refractory CMV? Generally, you need to have had significant exposure to an anti-CMV drug. Some patients who've had recurrent infection, or those that are getting subtherapeutic levels due to other reasons like poor drug absorption. Some transplants are more associated, like things like small bowel transplants. And then obviously your level of immune suppression as well plays a role. Generally, because the prophylaxis method is preferred over solid or over a preemptive therapy, that solid organ transplant recipients generally have more incidence of CMV resistance. And in some studies, this has been up to about 22%. So when should you suspect it? So persistent or recurrent CMV viral load or disease during a prolonged therapy. So generally, you wouldn't suspect it before there's been at least about 6 weeks of drug exposure, with at least 2 weeks of full dose at an appropriate dose. If you do suspect it, you should try send blood or tissue, less successful tissue, but blood for mutation sequencing. But this is really not done commercially here. Some research labs can do it with specific requests. So it is something that would really need to be discussed with the lab and with particular experts in South Africa. And how do you treat it? Well, initially you'd consider reducing your immune suppression to the lowest dose you can. If it's mild or asymptomatic, you can consider high-dose ganciclovir, so much higher dose, so 7.5 to 10 milligrams as opposed to 5, obviously watching very closely for the adverse effects. And if it's severe or life-threatening, foscarnet or cidofovir. If you have access to maribavir, that's an option as well, and I'll talk about that briefly. So it's not available here. It's a benzimidazole, and inhibits the UL97 gene. It's approved in the US and Europe for treatment of refractory or resistant CMV. But one of the weaknesses is it doesn't cover your other herpes viruses. So you would most probably need to use it along with other prophylaxis like acyclovir. It doesn't penetrate into the brain or the eye. So for those forms of disease, you would then have to use, let's say, cidofovir or foscarnet. So this was the major study that showed its use. It's called the Solstice study, where they randomized patients to either to maribavir or investigator decision treatment. And so that was generally foscarnet or cidofovir or ganciclovir at different doses. And it was showed with an increased clearance at week 8, so quite successful. And with also lower rates of AKI, neutropenia, and other treatment-emergent adverse events. Then finally, are there other new approaches for treatment? Well, I mentioned letermovir for prophylaxis. Some people have mentioned using it for treatment of refractory or resistant CMV, but its issue is it has a very low barrier to resistance, and it's probably better used as prophylaxis. But in desperate cases, maybe it's something that can be used off-label, but generally, you'd really need to be in a bind to use it. And then adoptive T-cell transfer. So this is also an emerging therapy. So it's basically giving a patient who has resistant or refractory CMV T cells from another patient which are CMV specific. But there's obviously multiple challenges with this, things like HLA mismatches, and also just the availability of donors. So it really is something that in its current form is not really a commercially or frequently available option. So considering the newer drugs, as well as what we have available at the moment, one thing I didn't speak about was the possibility to do things for the donor that may reduce the chance of in patients that are CMV positive, when the donor that you could do to try and reduce the incidence of transfer of CMV disease to the recipient. But you can imagine a world in the future where you could have an effective CMV vaccine, which you could give to recipients that are IgG negative. And then you could possibly do a baseline immune assay to assess your response before transplant. And there may be something you can do to the donor. So this is adapted from the study, from a paper written in JID by Haydar et al. And then you could post-transplant, you could then monitor the immunological response and see when you think that intervention may be necessary. Or you may give a monoclonal antibody at this point and then monitor the response and do a weekly CMV PCR. And if that jumps up, then you would treat. And if not, then you can just monitor. So this may be where CMV therapy may in the future go in patients with transplant. And I'll end there. There are some good resources if you're wanting to read a little bit more, guidelines for management in both solid organ and hematological stem cell transplants. This review by Fishman, there are a few nice reviews by Fishman just looking at infection and organ transplantation in general, which are very good and kind of really the goal, kind of give you some kind of fantastic baseline knowledge on infection and organ transplant. And I'll finish there.
Thanks so much, Lyle. It really is always such a pleasure when someone does a good CMV talk. It's one of the hardest topics in ID and very hard in transplant too. And you've done such a great job. Just looking through the chat for questions. where was it? Here we are. The duration, Narcisse was asking about the duration of ganciclovir prophylaxis, where you've given it, if that's the route you've gone.
Yeah, so it does depend on the organ transplant. So if you're using valganciclovir for prophylaxis, generally it will be a minimum of 3 months. So say for renal transplant where there's no complications, lung would give a minimum of 12 months. But yeah, it does depend. I mean, if you have other issues in between, or say patients, with rejection and requiring other interventions, T-cell depleting agents, then you may extend, but that would kind of be a ballpark figure. But yeah, obviously depends on the patient and what happens.
Yeah, and see, Ramani asked that is a hematology person. She's just left, but she made a comment in the chat about, I think you did mention, but about the very important point about letermovir, obviously only covering CMV and not the other herpes viruses. So you'd need some other agent to cover, say, HSV. Yes. You did use it.
Yeah, that's an important point. Yeah, valganciclovir gives good cover for your HSV and VZV as well.
And then Professor Moose is asking about any particular reason why the lung transplants are particularly vulnerable in the case of CMV.
I'm not certain that there's anything to do with the transplant itself more than the kind of amount of immune suppression that's required. Yeah, I mean, I don't know if you've got other particular insights. I mean, it's not particularly, yeah.
Yeah, I think you're spot on. I mean, I think the biggest reason is the lung transplants of all the solid organs are one of the ones which gets immunosuppressed the most, because the rates of rejection are very high. It's very, very, very vascular, obviously. There is some organ specificness to it in the sense that obviously lung is a target of CMV when you do have replication, and the lung itself, like we said, the transplanted organ is always a bit immunosuppressed, even independently of the amount of systemic immunosuppression. So I think for those two reasons, but I think the big one is the one you said. It's just the immunosuppression is higher, much higher if you say lung compared to say liver, which would be one of the lowest ones. Yeah, a real bug of it. I mean, you answered perfectly. I mean, it's really just very organ specific, the risk, unfortunately. Yeah. Be good if it was one size fits all. Make memorization a lot easier.